Good afternoon. My name is Mary C. Turner. I'm president of Minnesota Nurses Association. More importantly, I'm a COVID ICU nurse at North Memorial Hospital in Robbinsdale, Minnesota, and I just got off the weekend and got home at 7:30 this morning, so be nice to me. Thank you. But seriously, I want to thank all of you for being here today. Our message is urgent. We need the public, hospital executives, and elected officials to hear us when we say that the nurses are at a breaking point. I know about a year and a half ago we were in the same room, and I likened what we were going into as a war and that we were soldiers going to battle. And I'm telling you, we're losing the war. We're losing the war. The COVID-19 pandemic is worse than ever. ICU beds are full and patients are back in the hallways and waiting rooms. This isn't just happening in the Twin Cities, it's everywhere in Minnesota. But for us nurses, the crisis didn't start with COVID-19, it only made it worse. For years, our hospital CEOs hired and scheduled nurses at low levels to cut costs, putting revenues ahead of care at the bedside. When COVID hit, the burden of the pandemic fell on overworked and understaffed nurses. We have spent nearly 2 years on the front lines of the COVID-19 pandemic. We learned how to keep ourselves and our patients safe, even when we didn't have enough PPE, and you all remember that fight. But our hospital CEOs still haven't learned that they need to put workers and patients ahead of their bottom lines. Excuse for hospital executives who have failed to provide paid COVID leave, adequate staff levels for patient care, and safe hospital environment for everyone. I urge people to take the ongoing pandemic seriously as we head into the holiday. Case levels are at a record high, and 10,000 Minnesotans have now died from COVID. Get the vaccine and the booster, for God's sake. Wear your mask and practice social distancing, and get tested when you need to. To our patients, I want to say, nurses will be here when you need us. But to our hospital CEOs and elected officials, please hear us. Nurses need more than words. We need action to address the crisis of staffing and retention to Minnesota hospitals. We cannot go on like this. Thank you. I now would like to introduce Kelley Anaas from Abbott Hospital.
Hi everyone, thank you for being here today. My name's Kelley Anaas, A-N-A-A-S. I'm an ICU nurse at Abbott Northwestern Hospital. Thank you. So used to talking with those on now. Nurses have been talking about understaffed hospitals for years before the coronavirus showed up on our doorstep. I've worked as a nurse for over a decade, and it's a topic that's been front of mind for many of us for a long time. It only took a pandemic to get other people to pay attention. A process called benchmarking and cuts to staffing models by hospital executives manufactured this crisis long before the pandemic began, and now they want to cry COVID because nurses are leaving. To be clear, COVID may have exacerbated this situation, but the health system leaders created it. They burned out a lot of staff before the first coronavirus case hit our doorstep in Minnesota. The increasingly strenuous, and to borrow a couple of phrases, heartbreaking and overwhelming patient care conditions haven't made staying at the bedside any easier. For the last 2 years, our employers have relied on our sense of duty and taken advantage of our love of the job, each other, and our patients to limp us through surge after surge. The truth is, we can't keep showing up like this when they aren't showing up for us. On the cusp of 2 years since this pandemic started, we have all sorts of mitigation efforts in place to prevent the public spread of this virus. The ultimate goal being to avoid reaching a point where we were rationing care. Just because we aren't selling raffle tickets to see who gets a ventilator doesn't mean that we aren't rationing care inside hospitals. A patient boarding in an emergency department in rural Minnesota for days waiting for a staffed ICU bed at my hospital is rationing care. When I have an assignment of 2 critically ill patients, it changes the entire level and quality of care. The bar is no longer set at, did I progress the plan of care and make my patient a little bit better today? The goal changes to try to keep up and try and keep them breathing. That is rationing care. A lot of focus gets put on the ICUs, and I get it. It's where the sickest of the sick end up. It's where the drama is. What we also need to pay attention to are the medical and cardiac floor nurses caring for patients who belong in the ICU, but because of the scarcity of staff, don't earn their spot until they need a ventilator. It never used to be that way. As nurses, we're being trusted to take care of the sickest patients most of us have ever seen in our careers. We've kept up this pace for 20 months, and believe me when I tell you, we are languishing in there. And when our bodies and our mental health hit a point where we just can't do it, we're being questioned about our reason for calling in sick. We're told to take care of ourselves and then have our vacation days denied due to lack of staff. I want to say what has always been true to the hospital executives. If you take care of your staff, your nurses, they will take care of your patients. The quality of the care stays when experienced nurses stay. Nurses want to keep showing up to provide our expert care. The current patient care conditions are making it increasingly harder for us to do just that. Now I'd like to introduce Lynnetta Muehlhauser. Thank you.
Hi there, my name is Lynnetta Muehlhauser, and I am a nurse on the Minnesota Nurses Association Board of Directors. My concern today really is all the unstable conditions in our hospital. We have a decrease in our workforce, just like all the other workforces that we're seeing around here. We don't have enough members to do the work we need to do. So there's a constant strain on the staff that are there. Healthcare workers aren't just nurses and nursing assistants. It's also your environmental services, it's your housekeepers, it's your valets and that. We have drivers to drive the vans and things. Just like that, we are also seeing a lot of increase in ill calls, so that shortens our staff. So we don't have the numbers in our workforce, and we're seeing an increase in illness going throughout the metro and throughout Minnesota. The increase of sick calls has decreased our ability to care for these patients. More and more often, I see that I'm fighting to get enough staff to care for our patients. I work in a pre and post-op surgical center, and today in one area I had 11, 12 ill calls as I'm trying to scramble to cover those surgeries. One of the things that is overwhelming is when people don't believe that this is a crisis. The fact that we don't have the right staff to care for everybody sometimes, or we do, but it's really tight and we're sacrificing ourselves. So when families and patients come in and they want to play games and they want 3, 4 family members there, and we understand that people are hurting, especially when family members are really, really sick, but we don't have the ability to care for all of that. And when we say people, when we see and hear people say that they don't care if somebody else in their house is positive, or they don't care if they're having symptoms and they come into the facility, it is jeopardizing our health even more. Nurses and other workers facing this are having a difficult decision trying to decide if they should care for themselves and their own family members, or if they should come into work to care for these patients. Also, some facilities, one that I work in right now, says that the nurses also have to provide a doctor's note if they call off sick before they can use their earned benefits. We don't have essential health care worker benefits like other areas do, and so now these nurses have to decide if we're gonna already continue to stress and add more stress to the already overburdened healthcare system by getting a doctor's appointment so we can get paid, or by going to work when we're not feeling good and possibly jeopardizing making somebody else ill. So my ask is that everybody please get your vaccine, get your booster. If you're sick, stay at home. It's not just COVID right now, it's influenza, and there are a lot of patients that need to be in the hospital. Let us care for them, and let us do the best that we can by providing the best care we can. And also push back if you hear anybody saying that the nurses can't use their benefits. These are benefits. We have earned sick time and we're being told we can't use it unless we go to the doctor and strain that healthcare system more. Thank you. Next, I'd like to introduce Trisha Oxner.
Thanks, Lynnetta. Hi, thank you for being here. My name is Trisha Oxner. I'm an RN at Children's Hospital in Minneapolis. I've worked there for 30 years. I provide direct patient care in the PACU or the recovery room, and I also work in the day surgery department. We have watched the consolidation of our two campuses, St. Paul and Minneapolis. After strong negotiations which resulted in staff reduction by layoff and attrition, this happened prior to COVID and the RSV surge that we're experiencing right now. We have witnessed RNs who were contemplating retirement. They have left Children's. They've decided it's time to move on. We've watched RNs who can no longer mentally, physically, and emotionally tolerate the daily demands of short staffing and unsafe delivery of care simply to protect their license. They've also moved on. The unsafe staffing we have experienced for the past 2 years is no longer sustainable. Children's nurses have filed 2,800 unsafe staffing forms since January of this year. In previous years, we've filed approximately, on an average, 800 unsafe staffing. Prior to COVID, it indicates we had a problem. If we were filing 800 and now we're at 2,800. Children's was already stretched to a breaking point before this pandemic. Our nurses took action. We signed petitions, we met with leaders, we organized an informational picket, but management continues to ignore our pleas. We do not discredit the fact that the community can help to mitigate the current COVID crisis by getting vaccinated, wearing masks, making conscious decisions when gathering outside of their family unit. But the reality is that COVID has helped shed a light on a systemic problem related to unsafe staffing across the Twin Cities and the state. Short staffing has been a talking point and a crisis we have dealt with for years. Twin Cities CEOs, they have trimmed, sliced, and diced staffing and services to prioritize their revenues, which directly impacts patient and family care. An example is a plan to eliminate the pediatric intensive care unit and the neurosurgery department in the East Metro. It's imminent. We are stuck in a dysfunctional system that only perpetuates burnout and fatigue. This, in turn, it impacts the patient outcomes, as we've seen with so many deaths across the city and state. We can no longer listen to the rhetoric of leadership explaining their vision or plans for the future. We need appropriate staffing levels today and remediation of the past shortcomings by hospital executives now. As Florence Nightingale said, never give nor take an excuse. Thanks. I would like to introduce Wendy Wall.
My name is Wendy Wall. I'm on the board of directors, and I have worked at Sanford Health in Thief River Falls for over 5 years. I work in multiple roles within my facility, including emergency, med-surg, acute care charge, and I am floated to the ICU team. I live and love the unique environment of rural healthcare. What I do not love is the fact that for over 5 years, my facility averages 6 to 8 open positions at a time. This means that our 60 current nurses are supposed to agree to work 12 to 21 extra shifts every 2 weeks, or leave their work family short-staffed. These are mostly 12-hour shifts. That's 12 to 21 extra days worth of work that nurses are expected to spend away from their families every 2 weeks. This was all true before COVID-19. Our nurses have been holding together the broken pieces of our staffing plan. Nurses are only taking vacation to pick up the hours in the next pay period so someone else can take vacation. Or they're not taking vacation at all because they feel bad that there's not going to be enough staff. Management is not planning to fix this problem because we fix it every schedule. We have tried to address the root causes of our staffing problem only to get deaf ears from management. In our last negotiations, hospital executives were not willing to adjust wages to a community competitive wage, even though they were provided proof of higher wages at other facilities in the local hospitals. We knew of qualified nurses who would have applied if they didn't have to take a pay cut. COVID did not cause our staffing problem. COVID did not cause our nurses to be on the verge of burnout and exhaustion, but it has made the problem worse. With beds unavailable statewide, our rural healthcare system is facing the reality of taking care of sicker and sicker ICU patients without a system in place to provide the training to care for these patients. The rural ICU team is already stretched thin by being asked to pick up more shifts, and now they are asked to care for sicker community members. They are going home feeling discouraged and defeated. We became nurses to heal, provide for our communities. More than 15% of the staff on the ICU team are transitioning off that team. They're trying to find other jobs. They're trying to change positions within the hospital. The emotional toll is too great. They work too hard for their licenses to let the choices of corporate healthcare take it all away. Hospitals across Minnesota are facing similar issues. The community needs to realize that corporate healthcare choices are not just hurting nurses. Corporate healthcare choices are what have brought us to this breaking point. Corporate healthcare's business model has been exposed by COVID-19. Corporate healthcare, including hospitals, insurance companies, and pharmaceutical companies, have not been meeting the needs of our communities long before COVID. COVID just laid it bare. We will not fix this overnight. We as citizens, though, must come together and not only do our part, but reflect the mirror back on the hospital CEOs and demand that they do theirs. I'd like to introduce Emily Wright.
Thank you, Wendy. My name is Emily Wright. I have worked as a registered nurse in the emergency department at M Health Fairview Southdale Hospital for the last 7 years. Over that time, we have had staffing cuts over and over, year after year. I call it grid review. It increases the hospital's bottom line by paying hourly workers to do more with less staff, less resources, and yet sicker patients. Well, now our patients are sicker than ever, caused by the global pandemic and all of its fallout, creating gaps in care for millions, which have caused chronic conditions and new illnesses to go undertreated and underdiagnosed. Hospitals all throughout Minnesota are physically full, with all of their beds occupied by patients. It's been said that there's a nursing shortage, but nurses are showing up to cover those beds. The need that we are not meeting is adding resources back to those departments that are overwhelmed by these surges. Skeleton staffing models, regularly using the bare minimum of staff to stretch to cover each treatment area, have been implemented by our senior leadership to increase profits, and it puts nurses and patients in some of the most dangerous situations I have ever been witness to. ICU patients living in emergency departments. Typically, they would have a single nurse responsible for the high-level critical care. Now they're being cared for by an emergency nurse who may not have ICU training, doesn't know the medications or the treatment methods as well, and that nurse is also responsible for working with 2 or 3 other emergent patients undergoing evolving medical conditions in the emergency room. This scenario is playing out in emergency rooms across the state right now. Nurses like myself are at massive risk of losing our licenses in these situations, which we lose our livelihood and our availability to provide for our families. What is actually so much scarier, though, is the fact that while hospital CEOs continue to prioritize revenues over patients, all of us risk losing our lives and our loved ones unnecessarily. Our patients are in danger, and unless we make a change in how our hospitals operate, they will continue to be in danger. Having to wait 10 hours to be seen by an emergency doctor when you present to the ER is dangerous. Being on a ventilator on a hospital floor where the nurses are not trained to regularly work with ventilators is dangerous. Having critical emergent surgery and spending the night in the recovery room instead of the ICU with the monitoring and expertise that are proven to increase your chance of survival after that surgery is dangerous. In closing, we've all seen it everywhere. It is absolutely true that we are overwhelmed, and it is absolutely true that we are heartbroken. It's also true that the executives making this plea to the public are the ones who have the most power to help their staff and their patients. Tell hospital administrators that receiving health care in Minnesota should not be something that puts human lives in danger. Thank you very much.
So now you've heard it from the troops. And indeed, we're not doing very well. Indeed, we are losing the war. But let me be very clear. We will not abandon our patients. We won't abandon the public. We're going to keep muddling through. We're going to keep doing our job. What we are asking today is for some help. We're trying to shed a light on a problem that has been there for years, and of course exacerbated by the pandemic. But we will not abandon our patients. I repeat, we will not. But once again, I also, like I always do, I want to plead with the public that you must do your part. Please get vaccinated. Please get your boosters. Please social distance. Please wear a mask. Because we don't have any beds to care for you. This weekend, my ICU is full. Most of them won't make it. They're not making it anymore, folks. It did my heart good. I'll just leave you with one little thing. I heard not too long ago, someone who came in unvaccinated, wasn't ventilated yet, and he said, "Mary, I've learned my lesson. I'm going to take this seriously. I'm going to get my whole family to get vaccinated." And I said, "You just did my heart good." If we could everybody do that, everybody have a change of heart, we just make it through this. Thank you. Any questions?
So Mary, when you say you won't abandon the patients, you're saying this is not setting the stage for some kind of labor action, any kind of walkout or anything
We couldn't do that right now anyway.
Well, what's your ask of the legislature coming back in just over a month? Can the legislature play a role here in helping nurses?
I know we have had, like, I think Fairview Southdale, right, was one of the hospitals that have, we've had actually 3 federal teams that have come here, which, considering there's what, 6 total, 6 or 8 total. We've had the National Guard, you know, they're doing that, the various decompression sites, you know, to try to unload. But here's the reality is there's more people coming in than those kind of resources. So they've made the attempt. If you're referring to the essential workers bill, that's kind of going nowhere right now. So they're trying, but you know, we're up against a whole nation that is kind of in the same boat, except Minnesota right now Minnesota and Michigan are in really dire straits right now. I don't know if that answered your question, but.
You don't have, at this point, do you have an ask for the legislature when they come back into session January 31st?
Actually, yes, we would like to get our bid in on the surplus or something. Well, we want to get our bid in really quick here before someone else takes it. I don't know if that's the right way to put it, but I mean, for God's sake, use the resources to help hire the nurses, help with bonuses, help some of these rural hospitals that have no hope of getting extra nurses because their pay is so much less. I mean, I know for years that I've worked alongside of rural nurses my whole life in the metro, that as soon as they graduated out in rural Minnesota or in South Dakota, they got on the first train down to the cities. And that leaves places like Thief River without any nurses. So do what you need to do to get the pay, the bonuses. I've got nurses up in Duluth that they're quibbling over an extra $25 bonus or something. You know, and they got to beg for every $10 more or whatever. And then we're up against our travel nurses. You know, we're sitting alongside travel nurses. They're getting paid $200 an hour, some of them, depending where you go. So yeah, use some of those resources to kind of help us out. I'm not, help us out.
Mary, can I ask, a year ago at this time, the hospitals reported that they had more people doing patient care than they do now, which is why I think they're a little worse now. I'm wondering if you see that in your membership numbers or in your active members. Do you have fewer nurses in the MNA, or fewer active nurses right now as compared to a year ago, 2 years ago?
I don't, boy, that's a Corey question, you know.
I'll save it.
I will say that since the pandemic started, we've had Bethesda close. We've had St. Joe's that I understand is about to close. So if we have a decrease in membership, it wasn't anything that we wanted. We've basically closed 2 hospitals in the metro area during the pandemic, and we have downsized St. Paul Children's.
We also are seeing an increase in early retirement or retirement.
Yeah.
What people don't realize is a lot of nurses work until their 60s, 70s in the past. And what we've said all along is that the baby boomer generation is not being replaced. And so if we see a decrease, it's not so much, oh, these nurses are quitting right now at the moment, but people need to take care of themselves and they can't work.
I guess that's where I was going is, I mean, I hear a lot of talk about the pandemic driving nurses to other professions or just into early retirement.
Yeah.
I'm wondering if you're actually seeing that, if there's nurses are doing the same hard work today.
Yeah.
There's just a whole lot fewer of them than a year ago. Is that true?
Okay, so like on my floor alone, we've had like 37% of our staff have left within this past year. And they haven't left the profession, but they're getting out of the COVID ICU where they're desperately needed and going to another department. Some of it is having to do with scheduling and the staffing and just needing something different. You can't do the kind of work in a COVID ICU like what I do for 2 years straight and not feel its effect. You know what I'm saying? And so they're not leaving the profession, but they're moving around. Some are choosing to go do traveling. We have nurses in the city, you know, you used to think you'd go traveling and you go off to Hawaii or Florida. No, they're going to the hospital down the road. Okay? So nurses are on the move. And and I don't begrudge any one of them for do something different. Or trying to look for the rainbow. The end of the rainbow, okay? Is the grass going to be greener on the other side? I don't know.
Eric, Adam Duxer, WCCO. We've heard a lot of people in the last week say, like, oh, this feels like March 2020 all over again with this surge, right?
Mm-hmm.
But the one thing that's missing is any sort of shutdown or mask mandate or taking kids out of school, things like that.
Yeah.
When you talk about, you know, pushing for help from like an elected official, you know, level, is that something that you feel like we're in a position where we need to start asking for that again to like take a pause and shut down on things, or what can be done?
Yeah. You know, I'm glad you directed it that way. That helps me with this whole legislative thing. Because I've actually had nurses that say, Mary, where is the governor with all of the things he did last year? Why isn't he doing that anymore? And I have to like kindly go, I know you are some of the smartest people in the world here, you know, working, but that was last year when he had executive orders, you know, and he could do all that. And I've had nurses going, needs to bring him back. We're never going to get out of this. So thank you for that. That's what the legislative, you that want to know about what the legislative can do, they can take some more decisive action. I just read in the paper the Omicron now, we all got to worry about that. That's sweeping through like crazy. So like I said, I thank you for that question, because that's exactly what we need to do is start, put the foot down. Yep.
Mary Miller with the Pioneer Press. What is the Nurses Association's stance on vaccinating its own members? You're saying please get vaccinated, but hasn't the Nurses Association kind of fought a vaccine mandate?
We have not fought. What we have done, and like every other union, is we had said we need to bring it to the table. Like any other term of condition of employment, of condition, we said bring it to the table. I know that at our hospital we bargain for effects. And an example of that would be, okay, so I'll get my shot and now I'm out sick for 2 days. We want that doesn't count against our attendance record. That's called bargaining for effects. Okay? And so that's a legitimate thing that all organizations, all unions have the right to do, is to bring it to the table to discuss it. Okay?
But you haven't endorsed it. The general idea.
We have said that, I know our national has endorsed it, our National Nurses United, and that we realize that the most that we can do is to bargain for effects and to bargain for people to be able to have exemptions.
A lot of pleas here that are twofold. One is for the public to do what they can, but the other is for hospital administration to do more. What could they do in the short term? You know, I know a lot of this is long term, you know, the pre-existing staffing issues. What can hospital administration do in the short term to help the crisis that you're in?
I'm going to kind of go to my own, you know, when our director of nursing is asking that question, what are some ideas, you know? And we have a form that nurses can put their shift of choice and what their preferred hours, et cetera, are, you know? And I have said to them, I said, you see that list of the needs of, you know, the nurses and what they want to work and all that kind of stuff? Every single one of those should be filled. Give our nurses the schedules that they want to be successful. Because don't give me any lip about how we have to look for a balanced schedule, et cetera, because the schedule is leaking holes everywhere. So it doesn't really matter, does it? So that's one thing they could do right now, is to do our scheduling in a way that will make it more successful for our nurses. If they want straight nights, give them straight nights. If they want straight evening, you know, whatever it is. If they want to work a pattern, let them do it. And then you bring, because what happens is the travelers and the agency, and correct me if I'm wrong, ladies, But they come in and they get all the best hours. They get the straight days, they get the, you know, and then you wonder why our nurses are going off to work in agencies. So that's something they could do right now.
And that would allow it so that when you are away from your family, you can plan. You're picking up those
Right.
extra shifts, but you know that if you set these boundaries, like this works best for my family, they'll work with you. When they don't work with you and they're constantly asking for more and more and more, you're just like, I can't give more. I just can't.
Yep. Because it gets to a point where we'll have and things like that. We all have, at least in the cities, well, we all have some kind of bonus, but it gets to a point where it's not worth it. We can only do that for so long. Even the hardcore ones that are working 150 hours a pay period. And there are some that are doing that. Won't be able to do it forever.
And then a question for anyone that wants to answer this.
Oh, sure. I don't mean to hog them.
How many times through this last 18, 20 months have you felt like you've seen light at the end of the tunnel and then it's not there? And then, I mean, how many times have you felt like, oh, we're coming out the other side of this and then it gets worse again? Anyone want to step up and?
It keeps cycling. It's like an
Yeah, if anyone wants to address that at the microphones.
It's an ongoing cycle. We'll see the benefit of things, the numbers will drop, our surgeries will start to increase, and then all of a sudden the sick calls increase again. It's just an ongoing cycle. And now you're hitting influenza season, and then when you hear of like a city where they go to distance learning, not because there's not enough teachers, but because there's not enough bus drivers. So it's multifactorial, and I do keep thinking, oh, it's gonna be great, and maybe I can go out and eat and do this, and then all of a sudden it's like, oh, everybody's sick again. I personally know more people coming down with COVID in the last 6 months than I did in the first year and a half. I'm seeing it hit much closer to home. I know people that are being hospitalized, and I wasn't seeing that a year and a half ago.
What's changed?
Part of it is opening back up again. I don't know. I don't know. It's the variants. I see it affecting vaccinated and unvaccinated. So all I can do is do the best we can, is ask people to try to follow best practice on things and take care of themselves and their families so that we can take care of those who really need us. It's when we get all that extra, it's overwhelming us.
Do you see a light at the end of the tunnel now? Do you see an end to this surge right
I
now?
hope so. I love my job. I've been a nurse for 30 years, and I'm not ready to give it up. I'm a nurse because I want to be there and take care of people, and I want to make sure that they can go home and be with their families afterwards. But I need people to help me so that I can do that. And need time off, also, themselves, whether it's vacation or sick time and benefits they earned, they need to have some recoup time because they're burning out.
How many patients are you seeing are unvaccinated, and what factor is that playing?
I don't know.
I do want, your first question,
Yeah.
we had, after all the Governor Walz's mandates, et cetera, so it was like last June or July, and the positivity rate was down to like 1 or something, 1 or 2. We actually had a weekend. I actually had a weekend on my COVID floor where we had no COVID. And I was like, and we were all like, if we could dance in the streets, we would have been dancing there. We said, oh goodness, we made it, we made it. By the time I worked the next weekend, Delta hit. And it was bam, 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 1, 2, 3. All 3 patients came from the ED, not coming up on oxygen. They were coming prone, and you guys have heard that, where you're on your stomach and intubated. And all ardent, unvaccinated people. You ask me how many people in the ICU, I would say they're saying 90, probably over 90, 95%. Occasionally we get somebody that is, but also has a lot of other comorbidities that has been totally vaccinated that comes in. But they're almost all unvaccinated. And the other difference, and the reason why, when you say the light at the end of the tunnel, right now I don't see that light. I really don't, because the gentleman that I talked about, that he said, so he says to me, he goes, there's 2 or 3 times that I wanted to go get a vaccine, and then I ran into somebody who talked me out of it. And I said, well, that's the way it goes. You live in a community that is maybe 30-40% vaccinated, and you're gonna run into somebody who's gonna talk you out of it. So that's another plea I would have to people. If you have those kind of views, that's fine. You got your personal freedom, but keep it to yourself. Don't talk somebody out of getting a vaccine that wants to get a vaccine. Yeah. What was your other question? Oh.
I have a question.
I think that was it, I think you covered it.
I know we've talked big picture about being short-staffed. Could one of you or maybe several of you give an example of, this is how many people are currently, how many nurses are currently in our IC unit versus how many there should be
Right.
at a normal time?
I'm going to make reference to a hospital up in Duluth where, Duluth has got 3 major hospitals maybe? I don't know, 2 major hospitals for sure. 2.5. And they are like the safety net of the North. And their ICUs at St. Luke's are 3 patients all the time. They should have 1 to 2. A prone patient should be a 1-to-1. They are getting 3 and maybe 4 patients. Their nurses out on the med-surg floors on the night shift are getting 8 to 12 patients, and they should be having no more than 6. Okay? Even here in the cities, we're starting to talk more and more about, remember in the ICUs, 1 to 2 patients at the most? Starting to talk about 3 patient assignments. Or the charge nurse taking a full patient assignment. That's another thing that's very valuable and a resource that we all would agree that we need is an unassigned charge nurse, because that's your resource. Okay? So the med surges, I'm not quite, I don't know if any of you can address any of the med surg floors at all.
I can speak to that.
Can you? Okay.
So I made reference to this a little bit in my first remarks when we talk about what's going on the medical and cardiac floors, is that the acuity of those patients are such that they belong in ICU. And even even a year ago at this time, they would have been in ICU. And now there just isn't a staffed bed for them to come to. So they stay on the floor, struggling to breathe, having in and out of lethal cardiac rhythms, other complications going on that should make them, by all reasoning, an intensive care patient, and they just can't come to me. And the staffing doesn't get adjusted for that. Where like that patient will come to the ICU and have a nurse with them and 1 other patient, they stay on the medical floor with a nurse who has 3, 4, 5, 6, depending on the shift, other patients. And like when I talk about rationing care, is that like we are rationing our time and our knowledge because those other patients need us too. And while we would give anything to be able to spend the time and attention that those people need so that we can get them better and get them out of ICU instead of just having them sort of in this purgatory on the floor, like that's what happens. People, we don't get to progress the plan of care. We don't get to make them better. We don't get to push them to a unit that they belong in where they would have a better chance of a recovery and avoiding further complications because there's not a spot for them to go. And that's part of the struggle, is that like because we don't have an opportunity to progress those patients to a point where they're safe enough to fend for themselves a little more and safe enough to discharge home so that we can free up a hospital bed and lighten the patient load of a nurse. Like that's how we just kind of keep in this cycle. We can't get anybody better and people just get worse and there's no place for them to go.
Can I speak to it from a pediatric perspective?
I have an example I'd like to share. Historically speaking, RSV, it's respiratory virus, you've heard a lot of conversation about that, kind of peaks in the fall and winter, and we see a lot of hospitalization. We peaked with that at Children's back in July. So we've been
gangbusters since July. Furthermore, we were utilizing the summer months to do a lot of surgical cases of children who have time off in the summer. That's like ideal for families, catching up on any electives that had previously been canceled. With very limited bed space. So there's this new mentality. If you come in and you have a appendicitis and you get your appendix removed, generally you would spend the night. No longer is that happening. That patient is kept on our unit in our post-op area, and we just kind of ride it out and hope that they turn the corner, they're drinking, their pain is managed, and out the door they go. We're doing the same with a couple of other surgeries where historically these children would always spend the night, at least a 24-hour stay to help manage things. No longer does that happen. Gallbladder removals, we have some patients, tonsillectomy, adenoidectomy, maybe they're younger, 3 years of age and younger. We'd like to keep them to safely manage them. If they do well, it's out the door they go. Furthermore, we have patients that are coming in for surgical cases and warrant an overnight stay. There's no option in that, but there's no room, no bed space in the med-surg units. So what we do is we keep them in the recovery room for 2 to 4 to 6 hours, however long it takes to get a discharge up on the med-surg unit. Once that patient leaves, that room is, I don't know, cleaned very fast, which is concerning because everybody's being pushed. We got to move these kids out. That patient then is slotted into that unit, and if they meet their criteria, the next day they're discharged out. Out you go. We never would have in the past worked so quickly or pushed so hard or move these families and patients. We're also seeing a higher volume of COVID children that are being admitted into the ICUs. So that is taxing us. It's not just RSV patients now, which we're seeing those in addition. So it's not so much that we don't have always the bed space. We literally do not have the staff to take additional admissions. We kind of, in a pediatric setting, historically a nurse isn't going to take 8 patients. We look at our distribution of nurses to patient ratio a little bit differently. Inevitably it's necessary because they're pediatric patients. It can just go 2-fold, 3-fold, 4-fold. We also, our patients are ineligible, some of them, for a COVID vaccine, or the ones who are eligible now, we don't necessarily ask that they've been vaccinated or not. We're doing swabs on the child before they're admitted or having surgery. But I don't know if the parents have been vaccinated. I don't know, what they're gonna give to me and my coworkers and the other family walking down the hall. We don't have a handle on that. So I guess that kind of speaks to the whole idea of what Mary brought up. Just get vaccinated and stop making your issue everybody else's issue. I mean, that's a huge beg to the community. And if you're not vaccinated, wear your mask, put it over your nose and your mouth, wash your hands, just do what you can to help mitigate.
I was just going to say one other thing on top of that too is
Come to
that,
the mic.
one thing on top of that too though is the caution that don't be irresponsible if you're vaccinated either. Yes. If you're sick, stay home, get a COVID test. Don't live in denial that just because you're vaccinated you cannot spread COVID or that you can't get COVID. Because although you're not going to get as sick, you could give it to someone who has chosen not to get vaccinated, and then now we have a whole new problem. So yes, people should get vaccinated, people should wear their mask properly, but also we shouldn't live in a naive point of view that just because you're vaccinated that you should just throw your mask to the side and even if you're sick still come to work. So
Thank you. Just a drug
What I do.
On the numbers point here, I showed up to the emergency department to help the other day as frequent texts and pleas were coming out. There are 2 nurses working in triage and 1 emergency department technician who has been there for less than a year. Out of 14 nurses, we were short 4, so we only had 10. Out of emergency department technicians, we usually would have 6 or 7, and we had 2. However, we still had 2 nurses in triage and 1 tech in triage because there were 37 patients waiting 8 to 10 hours to see a doctor. We get limited information from these patients at triage. We do the best that we can, but it is the highest liability place to be in a hospital, waiting for emergency care while you're actively having chest pain, but we don't have a monitor to put you on. We don't have a bed to put you in. We don't have a nurse to watch you one-on-one and make sure that something's not changing and this isn't the big one, you know? And that means, you know, everything else waits. It means that people walk back out because they can't wait 10 hours. It means they're going hospital to hospital, putting resources on everyone, so.
I think we'll wrap up there.
Thank you.
Thanks, everyone.